So welcome everyone to today's virtual learning series. We're so pleased to provide this learning series in recognition of Victims and Survivors of Crime Week. We did receive a grant from the Department of Justice to host this learning series, and this is the first of two sessions that we're hosting. We're having two presentations today, and we have another one on Thursday, so we do hope you'll join us for that. Today, we're talking, the theme around our learning series is gender-based violence among older adults, supportive interventions. And we're looking at gender-based violence of older adults because we know it's sort of underserved population that we're not really talking about in that field. And there's a lot of work that's being done to address the issue of elder abuse and intimate partner violence. And as our colleagues today are going to be speaking on the work that's happening in the field. I will introduce our speakers after, but I do just want to indicate that our keynote speaker is Dr. Laura Mosqueda, who is a professor of Family Medicine and Geriatrics of the Keck School of Medicine at USC, and she's also the director of the National Center on Elder Abuse. Laura will begin our presentation and followed by Denise Koster, who has joined us for previous webinars, and we're pleased that she's come back to share her wealth of knowledge. She's also the CEO of Koster Consulting and Associates. So before we begin, I just want to provide our land acknowledgement. We acknowledge that we gather on the traditional territory of a number of First Nations and acknowledge their stewardship of this land throughout the ages. We seek a new relationship with the original peoples of this land, one that is based in honor and deep respect. So again, I just want to welcome everyone to our session. We're going to go through a few just basic logistics for today. As all webinars, our attendees are muted because we have so many people online. But just a reminder that there's you can post messages in the chat box and just ignore the speech bubble thing. That was an error. And if you have questions, please put those in the Q&A box. As I indicated, we have our ASL interpreter with us today. They will be coming on screen. If during the presentation you want to make their view larger, you can change your speaker view at the very top. There's a little grid and you can change it to speaker view only, or there's a line between the speakers and the PowerPoint presentation that you can change the size of the screen depending on what you want. As well as the closed captioning is enabled, so you can make that personalized on your own screens. So for the recording today for the session, the first presentation will be recorded and the second one at the request of the speaker will not be. Any resources and documents that are shared, and we do have some in the chat box, will also be posted on our website after the presentation. So don't feel like you're going to lose something or a link. If that's shared, we will post those after for your convenience and to able to download the information that's shared with us today. A reminder, we will be doing a evaluation of the sessions, and you'll get a reminder with a link for the survey. If you don't mind sharing a couple minutes of your time just to give us feedback, we'd greatly appreciate that as well. And we do respect people's privacy and confidentiality and respect the conversation that we're having today. We appreciate that people may have circumstances that they want to personally address. We just remind people that this is a public forum, that if you want to reach out about a personal situation, our EAPO staff are more than willing to sit and have a chat with you on terms of a phone call, I should say, to work through maybe the situation, provide some information and resources that might be helpful for you. So if you have that, we can you can send us a personal chat, and we can try to follow up with you after, or our information we've shared with you at the end of the presentation, where you can reach out to us either by our website or email, whatever you choose. and just having a respectful conversation. And for our conversation today, we know there's many topics out there that we're covering, so we'll do our best to respond to the questions. Again, if we have other issues that come up, we will try to provide those after the session. For those who are joining us for the first time and aren't familiar with Elder Abuse Prevention Ontario, we just want to let you know what our vision is. And what we hope to achieve is that all seniors are free from ageism and abuse, where human rights are advanced, protected, and respected. And we are, as an organization, implementing the Ontario strategy to combat elder abuse, which is funded through the Ontario government under the Ministry for Seniors and Accessibility. We've been implementing that strategy since 2003 and continue to work towards increasing awareness of the work that's being done across the province to respond more effectively to the abuse of older adults and prevent it from happening. So it gives me great pleasure to introduce our keynote speaker today, Dr. Laura Mosqueda. She's online now. Oh, there you are. We're so privileged to have Dr. Mosqueda join us. I know she's a very busy doctor, does a lot of work and research in this area for many, many years. And my colleague, Laura Proctor, and I have been wanting to have Laura for many years as a speaker. So we're so pleased that she's able to join us. I'm just going to provide a little bit of background of her work. Dr. Mosqueda is a professor of family medicine and geriatrics at the Keck School of Medicine at USC. She is widely respected authority on elder abuse and care of the elderly and underserved. She's also an expert on medical education, curriculum design, development, and implementation. Before joining USC, she served 16 years at the University of California, Irvine School of Medicine. Since joining USC, her roles have included chair of the Department of Family Medicine, associate dean of primary care, and the dean. She's also the principal investigator of an NIA-funded study to understand the causes of abuse of people with dementia, and is a director, as I said, of the National Center on Elder Abuse, a federally funded initiative that serves as the nation's coordinating body and clearinghouse for information on research, training, best practices, news, and resources. In 2022, she completed her fellowship with the Health and Aging Policy Fellowship Program. As a clinician, researcher, educator, and academic administrator, she has a unique perspective that is informed by her extensive experience in the community, including her role as a volunteer long-term care ombudsman. So we are in good hands, and Laura has promised to make this a very interactive session, asking for comments and having some dialogue during her presentation. So without further ado, I'm going to ask Laura to carry on with the presentation. Laura?
All of us who are attending this meeting today are a little bit weird. No offense, but we end up kind of having a biased view toward older adults and humanity in general, just by virtue of our work in this field. I love this picture. It was taken when I was doing a house call on a woman who turned 90. I frankly think the world would be a better place if we all were kissed by a large dog when we turned 90. But I want to start by reminding us that most older adults are doing very well and value their independence, and that we're really paying attention today to a very, very select group. Important to keep all that in mind. So what we're going to do today is talk a little bit about what it is about growing older that kind of gets associated with vulnerability to mistreatment, and why it makes it harder for me as a physician to detect and diagnose mistreatment. We're going to take a little side trip to talk about dementia and why there are special issues related to abuse and neglect for people with dementia. Spend a little bit of time talking about a few themes that I've seen related to IPV and intimate partner violence and aging, and then talk about a model we developed called AIM, the Abuse Intervention Prevention Model, which is a practical tool, not to be confused. On Thursday, you're going to be hearing from Dr. Weeks about AIM. Different AIM. We all can have different aims, and that's okay. I'm really pleased that Denise Koster will be following me to really focus more on the trauma-informed and using an equity and diversity lens. So I'm going to be paying more attention to kind of setting the stage for the rest of today and Thursday about aging kinds of stuff, a little bit about IPV, and a little bit about issues related to dementia. You are welcome to interrupt me as we go along. All of my slides, almost all of my slides, will be made available. I do have some unpublished data and some photos that I've taken off, but otherwise, all of the core material will be available to you, and I will be available to you. As far as I know, I'm not going anywhere. So, in the coming weeks and months and years, I am at your service as well. Well, unfortunately, there are many ways for an older adult to be abused. And we often talk about financial abuse. That's one of the most common kinds. But there often are multiple types of abuse that coexist, something that we call polyvictimization. So I like to remind myself and others that where there's smoke, there's fire. When you see one type of abuse, look for other types of abuse that might be present as well. What is it about aging that makes us more susceptible to abuse? And this is where, as a family physician, I'm a geriatrician, but also a family physician, I really think about a lifespan perspective. And there is more and more information now showing that people who were abused as children are more likely to be abused as they age, and are also, unfortunately, more likely to be abusive. There's quite a bit of literature coming out about this now, but certainly as a clinician, I'm always asking about childhood adversity, and this includes for people who in their 80s, 90s, and 100s, as we know more and more about the lifelong effect of having had adversity during childhood. But as age increases, even if you grew up in the most wonderful of childhoods, there are a variety of issues that come up that make us more susceptible. Issues like chronic illnesses, medications that may confuse the picture, depression, dementia, and the quantity and quality of social support as well. There are a variety of normal and common changes that occur with aging that make it harder to detect elder abuse and make us more susceptible. So for example, this is where you can join in the chat in just a minute. If you have an illness called osteoporosis, which causes loss of your bone density, couple of you put in the chat, what do you think this might make us more susceptible to as we age? And while a few of you are typing in the chat, and Laura will tell me what you're saying, let's also talk about other issues like your blood pressure might go down dramatically when you stand up. We're going to talk about daily living issues, function in a moment. In our neurologic system, our reaction time might go down. Do we have any responses in the chat yet?
Yes, so we're getting a lot of responses. So we're getting brittle bones, falls, injuries, chronic pain, balance, stabilization, mobility challenges.
Awesome. This is you got it exactly right.
Yeah.
And that's what a lot of these normal and common changes lead to. How we metabolize medications change. Our skin becomes thinner, what we call the epidermis. Epidermis becomes thinner. Our small blood vessels become more fragile. We may have changes in our hearing and our vision. So all of these things, you can now start to imagine how they impact things like likelihood to fall, and also problems with identifying an attacker if you can't see or hear them. So, so these are just important to keep in mind as we age. It means that as we grow older, it may be hard physically to defend ourselves from abuse. It might be emotionally harder to defend ourselves. Many of us fear losing our independence. So that makes us more susceptible to threats. Well, Mom, if you don't sign over your house, I don't really see how I can stay here and take care of you. You'll just have to go into a nursing home. That's an emotional threat. And it becomes even more of a threat when, as I have seen, the grandson who's saying this to her is waving a knife and sharpening his knife in front of her as well. We also sometimes become more reliant on others for assistance. And that also increases our risk, because now this nice neighbor who's helping get our groceries now needs our ATM card, now needs our password, now maybe is helping themselves because after all, they're helping you. And we can see how it can begin to spiral out of control. So these are the kinds of things that increase our risk to abuse and neglect as we grow older. And it's very important to understand the functional status of older adults when we're trying to understand the risk and context for elder abuse or neglect. I tell all of our medical students, I'm at the University of Southern California, that the geriatric F word is function. The biggest issue that a lot of people have as we grow older is maintaining our function, our physical function, our cognitive function, our emotional function. So we're always looking at functional status. I just would like to remind you that there's two kind of easy ways that we look at function. One is called the basic activities of daily living. And these are the types of things like, can you get around on your own? Are you able to bathe and use the bathroom? Get yourself dressed and fed? Because if you're able to do these sorts of things, you're probably independent within your own home. We also have a category called instrumental activities of daily living. And these are things that involve getting out into the community, like transportation, shopping. Are you able to handle cooking, which is a little more complicated, handling your own finances? Because people who are independent with their instrumental activities of daily living are likely to be independent in the community. So whenever I'm going out and I consult with adult protective services, police, etc., I generally want to understand these contextual factors when we're trying to figure out if abuse or neglect might be going on and the severity of it. So there's the functional issues, which we just talked about. Do you need help? If so, what kind of help? And then the other question I always have is, if you need help, why? Because you might have trouble getting dressed because physically you have osteoarthritis, or maybe you had a stroke and you can't move around very well. Or you may have trouble getting dressed because you have Alzheimer's disease and you can't figure out how to do it, but you can move around just fine. So we always have to dig like one level deeper than we initially think we need to. Got to understand the social complexities. Are there caregivers, paid, unpaid? Or is there family conflict? There's nothing like old family issues coming up during times of stress. Are there issues related to cognition, etc.? There's a lot of contextual factors that come into play. And we'll talk at the very end about how I try to make it easier to sort through all of these things. Let me take a quick pause and ask my buddy with a good name, her first name is Laura, if there's any questions or comments that we need to address before I move on to diagnosis.
Well, from one Laura to another Laura, there is no questions or comments right now, but you will be the first to know. So carry on.
Thank you.
Yeah.
Oh, all right. So I'm just going to pause every now and again like this in case you have something to say or ask or scold me about. All right. So let's talk for a few minutes about diagnosing abuse. Sometimes in medicine, we like to talk about red flags. Somebody has crushing chest pain radiating down their left arm, red flag for a heart attack. There aren't that many red flags for abuse. Occasionally there are, but there's more what I would call pink flags. And these are things that I might observe when I'm taking a history from somebody or hearing their history, what I'm observing in terms of interactions between an older adult and the caregiver who may or may not be abusive, what we're looking for in the interview, what I look for in my physical exam. And then also there's a lot I can look at with laboratory evidence like blood tests and radiographs, et cetera, which I won't be talking about today. But I just want to make you aware that we can look at laboratory evidence, and I often do when we're trying to figure out what's going on. The kinds of things I'm looking for are explanations. Somebody comes in with an injury, and whatever the cause I'm being told is just doesn't making sense. Or they're coming in and they have a pressure sore. And certainly pressure sores can happen despite reasonable care. Sometimes people call them bed sores, pressure sores, decubiti. They all mean the same thing. But why is it that this person wasn't brought in sooner? Why is it by the time I'm seeing this pressure sore, it's all the way down to their bone and it is infected and smelly? Why weren't they brought in earlier? So that's an example of a delay in seeking care. Are there injuries that just have no explanation? I don't know. I don't know how that happened. And you're looking at something that's a pretty severe injury. And then really looking at the interaction between what I call the patient, you might call client, we might call victim, but you get the idea, and the caregiver. Do we have, particularly for people with dementia, a caregiver who clearly is very impatient with them? And sometimes in the office setting, I'll just sort of stand back and watch them interact because it gives me a clue as to what the tensions might be at home as well. Now, when an older adult comes in with an injury, I can almost always find a reason that they have the injury that has nothing to do with abuse or neglect. But we have to have it on the list of possibilities because it can be hard to distinguish them. And in medicine, we too often assume that it's just because they're old. And this is what we hear all the time. Of course, they have a fill in the blank. Pressure sore, they're old. Fracture, they're old. Bruise, they're old. I hear that all the time, and it's a really big problem because while it may be due to an innocent cause, it may have been due to an abusive or neglectful situation. I'm not going to show you any graphic photos, but I do want to let you know that we have done studies to find different patterns. So I'm going to ask you to take a look right now and type into the chat, what are one or two things you notice on this, what we call anterior view, frontal view of a person? This was based on about 150 people. What do you notice about the bruising pattern where there has been an inflicted abusive situation versus accidental? And I'll give you a minute to type that in. Right. So face, arms, torso, grabbing too hard. You got it. Perfect. More upper body. Exactly. And now I'm going to show you from the posterior view. And you see similar upper torso, head, neck. Now, it doesn't mean that every bruise I see on the face is due to abuse, but it does mean we want questions to be asked. I'm very glad that these data from our studies have made it into textbooks for nurses and physicians and into the emergency room so that we don't keep making that assumption of course, they have a bruise, they're old. that there are some things that might want to make us look more closely. Similarly, my friend and colleague, Dr. Rosen, who's at Cornell, an emergency room physician, looked at injury pattern comparisons from people who come into the emergency room due to a fall, just an innocent fall, nobody pushed them, versus injury patterns in people where abuse was proven in court. And one thing he found that I think is very interesting is that 1 in 5 people who were abused had no visible injury, but they had pain. So it's very important to note when somebody is either complaining of pain or may have tenderness somewhere, because that might be our only physical indicator of abuse or neglect. He also found that there were more injuries on the left side of the face in particular, and neck injuries and ear injuries. So again, when an older adult comes in with injuries on the head, face, neck, be it bruising, fractures, etc., we really particularly have to think about abuse or neglect. There are lots of other markers that potentially could be evidence of abuse or neglect, like burns or cuts or scrapes, broken bones, etc. We won't go into them on this talk, but these are the sorts of things that we look for, and we're really trying to train healthcare providers to think about as possible indicators of elder abuse. Due to our frustration with horrible documentation when an older adult comes in with an injury, we developed something called the Geriatric Injury Documentation Tool, or GeriIDT. And this is a way to help make it easier to document an injury. And it does 2 things. It makes it really easy to document, and I'll show it to you in a minute. And it also shows you what to look for and document. So it's 2 pages. You can just print them out back to back. Again, you'll get these slides, but this is the website at the bottom of this slide where you can just go and download the document. And it's a body diagram. Lots of us have seen these body diagrams before, but the idea is to just be able to circle an area and then write in 4-centimeter bruise, purple, or whatever, to make it very easy for clinicians to document these things, including where there's pain or tenderness. There's another page to this that I'm not showing you today that kind of reminds us how to stage a pressure sore, what to document when it comes to bruising, so that we're hoping if this gets some uptake that will improve documentation of bruises. I'm going to pause again for a moment because the next thing I'm going to do is talk about dementia. And since we're moving to a new topic, I just want to check in and see if everybody's doing okay, or if there's any questions, comments, or concerns so far.
So
Thank
there
you.
was, yeah, thanks, Laura. That was quite interesting. So there was one question about the marks on the arms. Somebody was asking if do the posterior lower arm indicate an attempt to protect themselves or is it clear cut that it is abuse?
Yeah, it's almost never clear cut. This is why I talk about pink flags. So these can be defensive, but this again is where I want to know what is the person's functional status, and can they just tell me why they have that bruise? Because I've seen people with horrible bruises who have had a perfectly rational explanation, weird but rational explanation about how it happened, and were able to assure me that they weren't abused. I think the main takeaway for me is you have to ask. And after you ask, you have to listen and think critically, did that explanation make sense? So if I have somebody, for example, who's bedbound, they can't get up and walk, and they have injuries here, I'm really wondering how they were able to bump themselves and get those injuries. Versus somebody who's playing pickleball twice a week and fell and scraped themselves on the pickleball court.
Right. The other question I was wondering, is there a difference when you're showing those graphs between men and women? Or is it
I don't know.
consistency between genders?
Right. I don't know the answer to that. That study, to my knowledge, has not been done.
Okay, thank you. There was a question just as if you were doing this, I think as a physician, doing these assessment, at what point, I know there's laws are different than the states than they are here. But when do you involve police? Is after they disclose, or do you have to get consent, or how does that work?
Um, uh, so to make it even more confusing in the United States, every state has a slightly different law. Where I am most states have mandated reporting. So that if the person lives in the community, we call our adult protective services or the police.
Right. Okay.
And then, yeah.
And would this chart that you just showed us, would that the tool, would that be applicable for long-term care homes?
Absolutely. Long-term care homes can use this.
Okay. Perfect.
And they do have body diagrams. I don't think they don't really get to all of these areas because we get into we get into genital areas, mouth, etc., which they don't typically do, but can be very important, especially when we're worried about a sexual assault. And we're also, as you see, very careful to have a picture of the neck, because we know based on studies that that's another area that's vulnerable with abuse.
Great. And then there was just one last question regarding pain. How do you differentiate pain from intentional injury versus unintentional?
You have to ask. The main thing is to document that somebody has pain and where the pain is. And then you ask the question. As we'll talk about in a moment with dementia, sometimes you have people who can't answer. And this is depending on whether I'm wearing my clinician hat or my expert hat. By the time I'm an expert, I'm looking at documents and I'm looking at functional status, etc. As a clinician, I might just be putting a documentation in the chart that this person has pain. I don't know what it's from, but if they keep coming in with other injuries over time, I might say, hey, there's a pattern here that really has me worried.
Great, thank you. That's all the comments at this point.
Thank you. All right. Well, let's take a walk down memory lane. The first thing is to just acknowledge there's a lot of different reasons people can have problems with their memory. If I try to tell you something while you're asleep, you're not really likely to remember that. So that's kind of our most basic thing, right? We need to be awake. We have to be alert. We have to be able to pay attention. We have to be able to get the information in, which means we need to either be able to see it or hear it or understand it. Once we get it in, we have to put it somewhere in our brain. And once it's sitting somewhere in our brain, at the right moment when we need the memory, we have to go in and find it and pull it out. So there's a lot of components to memory, and a problem in any one of these areas can make us have memory loss or memory impairment. The issues related to alertness and attention occur with things like depression, where you can't really, you might just be too sad to be able to pay attention. It can happen with medical problems like delirium. It can happen due to medication side effects. Getting information in can be due to hearing loss, vision loss, inability to understand information. Storage problems are what we tend to see with Alzheimer's disease. And retrieval problems are what we tend to see with what's called vascular dementia, or dementia due to either low blood flow or certain areas of the brain that don't get adequate oxygen. People often ask me what's the difference between dementia and Alzheimer's disease. And it's a little bit like asking what's the difference between a car and a Volkswagen. Right? Car is an umbrella term, and we all know what a car looks like. And a Volkswagen is a type of car. Dementia is an umbrella term, and Alzheimer's disease is a type of dementia. So in order to use this umbrella term of dementia, somebody usually has memory loss and some other kind of a problem, like trouble with judgment, language, spatial relations, mathematics, etc. And those things have to impair their daily function. So that means I need to know where somebody starts in order to know where they are now. Because you've got people like me, I'm horrible with spatial relations now. So when I get tested 10 or 20 years from now, I'm going to be bad at spatial relations. And unless it's a drop, that's just me and my brain. Some people are really bad at math to start with. So we always need to know where somebody is starting, and we need to know what their general function is like and whether their function is impaired in order to say they have a dementia. And then we move on to diagnose the type of dementia they may have. We know now that with illnesses like Alzheimer's disease, it may start when we're in our 40s. And we can find brain changes that we sometimes call preclinical Alzheimer's disease. And gradually, these changes take a march through our brain until they finally show up and we have functional difficulties due to them. People who live with dementia are at much higher risk of being abused. It's estimated that 1 in 3, maybe as high as 1 in 2 people with dementia will be abused or neglected at some point. But they may be unable to even recognize that they're being abused, or if they're concerned, they might not know how to use the phone or report it. And the other thing we find, sadly, very commonly is nobody believes them. This is weaponized sometimes. I have a very sad situation going on right now where a person who explained that her son-in-law was sexually assaulting her was not believed because he immediately said, "You can't believe anything she says. She has Alzheimer's disease." And unfortunately, she was not believed. But we're getting her appropriate care now because too many people made assumptions about her being old. So we don't think of older people as, any sort of sexual possible abuse happening. And because she has Alzheimer's disease, that she makes stuff up. And when I heard about this, was able to explain why I did not think that she was likely to be making this up. And she's being brought in for an exam now. I don't have data to support what I'm about to tell you, but I will tell you my observations that people in the early stages of a dementia are very likely to be financially abused because they look good, but they're kind of easily confused and tend to have a lot of trouble with math. People in the more moderate stages of Alzheimer's disease who have more behavior symptoms, like they're resisting care, they're following somebody around, they're asking the same question over and over again, these folks are more prone to physical abuse. And the people in the late stages, when you get to a point where you might be nonverbal, you have trouble communicating, you might not be able to walk anymore, these people are much more prone and susceptible to neglect. Now, I want to be very careful here that we're not victim blaming, right? If you're in the middle stages of Alzheimer's disease and you have a lot of what people call problem behaviors, a term I hate, that doesn't make it okay for anybody to hit you. And it turns out that whether or not you get hit has much more to do about the person who's caring for you than it does about your own behavior. So I'm always asking a lot of questions about relationships, how people feel about caregiving, etc. And we'll talk more about that a little bit later. The other thing is when somebody tells me that there's a problem behavior, I really try to reframe it into, what suffering is this person trying to communicate to us through that behavior? And sometimes that kind of a reframe can help us be both more empathetic and more helpful to the person that we're there to serve. Some of the studies that we've done show that caregivers who have very high expectations for what they're going to do for themselves and the person they're caring for tend to get more distressed and are actually more likely to be abusive. We found that caregivers who are better at regulating their own emotions, and also if they feel appreciated and they've always had a close relationship, are less likely to be abusive. And we also found that care providers who are very distressed and feel burdened are much more likely to be abusive when we meet them. So this is very practical implications for questions I ask when I'm caring for somebody with dementia, or when I'm called out on a possible abuse kind of a situation, because we want to ask these questions. But the other thing these sorts of data do for me is they give me hope. And the reason they give me hope is we can ask these questions early. And if we know that these people have never had a good relationship, and this care provider is not happy about providing care for her mom, we can ask those questions early, help them intervene and prevent abuse from ever happening in the first place. And that's a lot of the work that we're doing right now. So caregivers should always be asked about their perceptions. And I find that sometimes I have to be careful that I don't make bad assumptions. I'll see somebody who seems pleasantly demented, they're not having behavioral challenges, and so I think everything's fine, but I ask the caregiver and I find out that the caregiver used to be hit by this person, they're trying to take care of little kids, they're not at all happy about having to do this. That's all stuff I want to know now so that I can ask some follow-up questions. Wow, this is really stressful. Have you ever hit your mom because you're getting so frustrated? No? Have you ever felt like you might hit your mom? You have? Okay, let's talk about what to do when you feel that way, because you need to understand it is never okay to hit your mom. And I want to help you so that that never happens. That's why we work in teams, by the way, and we'll talk about teams in a few minutes. But it means that screening is essential and we have to ask these questions. Now, before I go on to talk a little bit about a few themes related to IPV in elder abuse, let's just do another pause and see if you're still awake, because I promised Denise I wasn't going to put you to sleep before her talk, so don't make a liar out of me. Any questions or comments?
Laura, there was somebody looking for maybe some more specific open-ended questions of how you would actually ask the caregiver or the loved one questions without being too offensive or invasive.
Yeah, well, I'll tell you what I've learned. And again, Denise is going to really be talking about trauma-informed approaches, etc. But what I've learned is that you can be much more, I can be much more straightforward than I ever thought. So what I'll do is I'll say, I just want to ask you a few questions. I ask everybody these questions. Are you afraid of anybody? Is anybody hurting you? Is anybody using your money without your permission? Very straightforward, calm, normalizing it, etc. But I think the key for me is, we all get pulled in a million different directions. And I think the most important thing is our tone and our body language in addition to what we ask. So sitting down at eye level, their hearing aids are in, their glasses are on. And I don't think they're leading questions because it's just, has this happened to you? And so I've never had any law enforcement folks be concerned when I ask those sorts of open-ended questions, because it's just opening it up and giving them permission. And what I need to do is let that person know that at that moment, the only reason I exist is for them. And it has to come from not only my brain, but my heart and my whole body, in order to help gain some trust and understanding in a fairly short period of time that this is a safe place to talk. We can't have potential abusers hovering around or walking around. We really want to create a safe environment for folks. And if we have time later, I'll be happy to talk about family members that don't believe the diagnosis. That's a whole nother thing that's really, really important. My brief version of that is I need to understand why they don't believe the diagnosis. And there's usually a lot more behind it. It could be anything from lack of knowledge to guilt, to disrupted relationships. And so I usually need to understand why they don't believe it, and try to get to the root cause. All right. I'm gonna keep moving forward here and talk a little bit now about some IPV issues in the context of aging. And we sometimes say that this intersection of intimate partner and violence and elder abuse is really kind of tricky sometimes. And you end up with a double whammy. Like, not only have you suffered from intimate partner violence, but you're old, and now you're really invisible. And most IPV research does tend to focus on women of childbearing age. And in fact, in the United States, we're told to, if you want to, you can screen but they don't talk about screening older women. So we really don't pay enough attention to this intersection. I think one of the reasons is, here are some of the symptoms that occur with intimate partner violence: disturbance of sleep, problems with digestion, trouble concentrating, feeling depressed, maybe worthless, chronic pain. So these are kind of common symptoms of IPV, and they're also common symptoms of aging. So sometimes as we get older, we have trouble with sleep, digestion, concentration, etc. And so it can make it really hard to figure out what's going on. I'm just going to go through a few themes that I think exist that are different types of themes in IPV and aging. One is, if you've experienced intimate partner violence earlier in life, you now may have a lot of traumatic symptoms well into older adulthood. I have found in my clinical practice people who've divulged stuff to me just because I asked, using a trauma-informed approach, about earlier experiences. And they're 92 years old and have never told anybody about it before, and are bursting at the seams to talk about it. It also can come up in special circumstances when somebody has a dementia, or they're in a nursing home and people are trying to change them, and they're reacting very violently when somebody's trying to change their diapers or get around their genitalia. It might be because they had an earlier experience where they were sexually assaulted. We just don't know. So there's IPV earlier in life. There's also intimate partner violence that occurs related to these power dynamics, where you have a couple who've been married for 40, 50 years, and there's always been this history of violence between them. And for them, it's almost become normal. And now you have one person, let's say he develops Parkinson's disease, and now she's the one who views him as a potential victim, because the power dynamic is now shifting. So we have to be careful that we don't just have somebody going, well, he used to beat the crap out of me and assault me, etc., and now it's my turn. That's all horrible, but we're still not going to let the other person get abused. So this shifting power dynamics and a long-standing history is another theme that I see. And finally, I'll mention another theme, which is new onset. You have an older adult who's never been exposed to any type of violence. But now a spouse dies, they might become more susceptible to taking up with the gardener. Just recently, I'm dealing with a situation where that's the circumstance. He's in his 50s, and he clearly kind of groomed her, and now they're involved in a cycle of violence. So sometimes there's this new onset where this person never in a million years would have thought they would have been susceptible, but can become emotionally and then physically susceptible to intimate partner violence as time goes on. I think there's a lot of barriers to figuring these things out. You know, the internal barriers to the person experiencing them might not even know who to talk to. They might not trust others. They may feel like, I'm just old, so it doesn't matter anymore. There are also external barriers where they might be dependent on that person economically or physically. They might not feel supported. And there can be a lot of controlling tactics that go on. The abuser is isolating them. They've removed their cell phone or access to a phone, or they just say, gosh, your son must not love you anymore. He never calls, but it's because they're blocking the calls. And I think there are a lot of barriers to intervening as well. Like, we're just not, that's why I'm so grateful to Rayanne and your group for inviting me to talk about this, because we need to make people more aware that this happens. And I think we're all trying to work at how we can cut across silos so that there's more ability for us to work together on behalf of the people that we're serving. But even shelters often can't handle having an older adult in them or somebody with dementia. So we don't have all the age appropriate services that we really, really need. I think there's lots we can do personally, professionally, and across agencies to make things better. I have a slide with a lot of ideas on them. I'm not going to read them out loud to you, but I offer it to you for your consideration, things that you can look through later. So before I launch now into talking about this model called AIM, again, not the AIM that Lori Weeks, Dr. Weiss is going to talk to you about on Thursday, let's take another pause and see how everybody's doing.
Thanks, Laura. So we're getting a lot of great engagement in the Q&A. One question, somebody is wanting to really understand what you think about families actually being open to talking about maybe their potentially abusive behaviors. We all are very well versed in working with abusers that will never see their behavior as abusive. So how open have you found in your experience that families are willing to talk about this?
I would say most are and some aren't. And the ones who aren't are the scariest because they don't have this insight and have reasons of their own that they're not capable or willing to have insight. So that's when I look for other allies. It might be other families or other social organizations that can keep them apart and keep the temperature down. So for example, if they're caring for somebody with dementia and they just have no choice, this is where this person has to live. And I have a family who, despite a lot of our attempts to explain that dad can't help it, that he follows you around and asks the same question over and over again, and we can provide you with techniques and role modeling for how to do better. They just aren't able to see it that way. They still think it's willful on his part. Then maybe we really want to look for a daycare program, an adult daycare program, so that he's out of the house a lot of the day, or find other ways to keep them apart. But really, the majority of the families I work with are able to understand and accept if we find the right way in. So I'm always trying to find the right way in. And when I can't, I ask for help. I rely so heavily on my team members, be it other physicians, nurses, psychologists, social workers, who may have better ideas, new ideas, other avenues in. That's why the team approach is so important. All right. Thank you for that question. And if I didn't answer it adequately, please let me know. So we've talked about a lot of complex things, and at the end of the day, I am a simple-minded person. So this is my simple-minded approach, which is this abuse intervention prevention model. It's a very practical framework where we look at 3 domains. What's going on with the older adult who may be being abused or is at risk? The potential abuser and the context of their situation. And sometimes when we look at all of these different domains, we can begin to get a feel for what's going on within these domains that might be amenable to change. Because some characteristics are fixed. If one of the issues for the older adult is that they have a history of past trauma, I can't change that past trauma. But perhaps we can work with them to understand it differently. If they have a dementia, I can't change the fact that they have a dementia, but I can look for things that might be causing excess disability. If their trusted other, the person who's taking care of them, has certain personality characteristics that make them more easily angry or anxious, perhaps there's things we can do to help with that, or find them help for their substance abuse problem. If they're living in a neighborhood that has a very high crime rate and it's hard for them to get out safely, we need to list that as an issue and see what can we modify. I can't change the neighborhood, but maybe we can find safe ways so that they're not socially isolated. So I use this framework to look at what's fixed and what's modifiable. I'm now going to go through a case example with you, and I would like everybody to think about those 3 boxes: the older adult, the potential abuser, and their context. And as I'm telling you the case, jot down what you think might be worrisome characteristics in each of these domains. We have Mrs. S. Her husband is 86 years old and has Alzheimer's and brings him to the primary care. His dementia is moderately advanced and he needs help with taking a bath and with going to the bathroom, and he needs help with dressing. And he doesn't really like it when people help him. He's kind of resistant and pushes her away. The last time his doctor saw him was 6 months ago, and he's really declined a lot in those 6 months. The doctor also notes that his clothes are not clean and he smells like urine. We get a social worker involved, and she discovers that the wife, Mrs. S, is really the primary caregiver, and she has her own health problems. She's in her 80s, and she needs help getting around, and it's just really hard for her to help her husband because of all the pain, joint pain that she has. She also finds it really stressful. She has her own pain. He's resistant to care. She starts feeling nervous all the time. Her sleep is disrupted. And we learn that they've been married for 30 years. They've never had children, but he had children, 3 children from his prior marriage, and they have always disliked Mrs. S. So 30 years on, she's never been accepted, never been acceptable, lots of strain. And she is financially secure, but she's never the one who managed the finances. And she's not really comfortable now trying to handle all the finances. She feels like no matter what she decides, the kids are going to be critical, and they're not going to like whatever it is she decides regarding his care needs. And she's so stressed that she's stopped doing a lot of her own activities. She's not seeing her friends anymore. She has to provide care for him and be around all the time, and the kids are always on her back, and she's feeling really isolated. So I think you get the picture. I think a lot of you have seen a situation like this. Let me pause and ask you to help me fill in the boxes. And if it's possible to start with the vulnerable older adult, with Mr. S, what are some of the things that you think make him more likely to become victimized? Impaired cognition, absolutely. Isolation, 100%. Can we get one more? Oh, resistance to assistance, perfect. And physical limitations, you got it. Now, what is it that worries us about Mrs. S that might make her likely to be abusive? Overly stressed. She's both isolating of him and isolated herself, right? Burnout, feels like she lacks support, poor sleep, you've got it, right? Pain. And what is it about the context of their situation that might not be so much a personal characteristic of each one of them, but something about the context of their situation that makes you worried? Strained relationship with the kids, that's a great one. No unconditional support, 100%, right? Lack of help, you got it. All right. So I think I came up with some of the same things that you did. He has a dementia that limits his ability to care for himself. He's resistant to care. She's probably suffering from depression, anxiety. So, and we talked about the context, right? Strained relationships, limited social contact. Are any of these amenable to change? Can we help with any of these things, or is this just what it is? We do need to help. And guess what? Depression and anxiety, those are treatable illnesses. There are caregiver support groups. We can help, right? Reduce isolation, connecting them, right? Teaming, enhancing social system, all exactly right. Family intervention. Sometimes people say this about their stepchildren, but when you actually bring them together, there's never been a family conference or an attempt to say, you know what, can we all agree that we're here for your dad and your husband, and how can we work together? And sometimes, to everybody's surprise, they're able to work it out. Counseling can be very helpful, respite, you've got it. And so when we look at a complex situation and think about these different domains, sometimes it helps me figure out what can we do something about and which things are we just sort of stuck with. Excellent, excellent. So this idea about, I think, working in teams is really important, and we're all pieces of the puzzle. and you never know which member of the team might need to be involved. I certainly am working in teams that I never thought I would be in. We also want to remember that it is the person we're serving who is our team leader. And it's something that sometimes, especially in elder abuse, that we sometimes forget. This person-centeredness, this idea about what are the goals of this older adult, even though we might disagree with them. The big argument between autonomy and safety, as one of my good friends says, and I'll show you her book in just a minute, we want autonomy for ourselves and safety for our loved ones. But when we're trying to give everybody some autonomy, we need to look to them to be our team leader. Well, I'll just conclude by saying I never expected to be going on house calls with the police. We never know what kinds of teams that we'll really be working in. I also have a sign here for you. It says caution. This sign has sharp edges. Do not touch the edges of this sign. And then in small print, it says also the bridge is out ahead. This is a reminder for me that sometimes you have to pay attention to the little stuff, the subtle stuff. And that might be what is actually most important. But we have to go in open-minded, open-hearted, so that the people that we're there to serve are really able to talk to us and that we're able to listen. We also have to ask the right questions. This is a photo that shows cats sitting on different areas that are dented, a dented windshield, a dented roof, a cracked pavement, etc. And so we can ask, boy, these cats must be heavy, but that's not really the right question to ask. There's something going on underneath. And the right question is, what is happening underneath and how do we get to that? So elder abuse is a big deal. It affects at least 1 in 10 people over the age of 60. If you have a dementia, it raises the risk dramatically. It makes us more likely to die, not due to the direct cause of the abuse, but just being in an abusive situation. And just like there's secondhand smoke when you're around cigarettes, there is secondhand elder abuse. So it not only affects the older adult who's being abused, but it impacts everybody who loves them. Most elder abuse is never reported, yet the price, be it the economic price, the human price, the moral price, is very high. As we think about the very opening slide I showed you of the 90-year-old woman being kissed by a big dog, it makes me think about some of the special things that can happen for older adults and that I think we all wish for ourselves and those we love. The wisdom that comes with aging, being curious, still learning as we go, being really ingenious about how to solve problems, having a big global perspective. And also some older adults are lucky enough not only to be wise, but to also experience some transcendence, a true appreciation of the beauty and excellence around them, feeling gratitude and hope, linking to their own spirituality, being able to forgive and love and do things with a zest and a sense of humor that really helps them enjoy some of the difficulties that occur with aging. My friend and colleague, M.T. Connolly, wrote this book that just came out, oh gosh, less than a year ago, called The Measure of Our Age. Despite the fact that I'm in it in parts, it's a very good book. And she talks a lot about wisdom and awe. She talks about issues related to safety and autonomy, and I highly recommend it. Canada's own Laura Tamblyn Watts has just put out a book, which I have not yet read, that talks about having difficult conversations with aging parents. And I look forward to reading that book. No matter how old we are, we all want meaning and comfort and identity and joy and inclusion and love in our lives. And I think that's what we're trying to do for ourselves, for the people we care about, and for the people we serve. These slides will be available to you. We have a lot of resources that will be available to you as well. I'm going to stop sharing my screen now so that we have a few minutes for Q&A or a break or whatever it is you need. It was truly a delight to talk to all of you, and I very much appreciate your attention.
Thank you so much, Laura. That was fantastic. Um, lots of emojis coming up there, and sort of thank you for your presentation. It was a really great overview. I was making notes of, I really like the comment about the older person being the leader in the team. And I think sometimes we do often forget about that when we become into the teams. It's like, who's going to take on the case as the leader, as versus the person centered in the situation. And you've just highlighted so many issues around the context of looking at the issue of abuse and the different mechanisms and the way that we need to look at this and how we address it. I'd love to have you back, because I know there's lots of questions I think that came up around the interviewing. How do you approach someone? I know there was a question about how do you approach a family member about if they're harming someone in a way that they might even respond to that question, because they may often take offense to say, I'm doing my best and as I can, but how intrusive of you to even ask that kind of question. And so I don't know if you have any strategies around that.
Yeah, I'm very straightforward with it. Again, so there's the rare situation where I think like it's a scary caregiver and that's a whole nother situation. So I'm going to talk about the majority that I see, which is most people don't want to be yelling or hitting or grabbing or handling roughly. And so I really approach it as empathetically as I can. And I might say something like, I might pull the caregiver aside and say, wow, I can see your mom is a handful. And I can just see that you're kind of correcting her and trying to help her understand the reality of things, even though she can't understand it. Sometimes when people are in these sorts of situations, things can escalate. Are you ever finding that you're getting rough with your mom physically or yelling at her? So I'm pretty direct about that. And I think, again, for the majority, if people know that you really care, they're willing to tell you. Now, again, I have mandated reporting. So if somebody says to me, yeah, I did, I lost it and I hit her, I'll say, I'm really glad you told me, again, so that this never happens again. And I want to help you. So I'm going to call a social worker from Adult Protective Services who's going to come to your house and we're going to help you figure out what to do. So it's not, you're an awful person, I'm going to call EPS and have them come. Well, I'm now trying to set up a good situation for my colleague in Adult Protective Services, because they don't come and drag people out of the house. I mean, they come to help, again, unless it's in one of those rare, really violent, explosive situations. So I'm pretty straightforward about it. The other thing I'll say, and then we'll go to the next question, is I've learned to ask not only, are you doing this, but are you afraid that you're going to do this? So I'll say, are you afraid that you might hit your mom? And I've had people say, I've come this close, I've come this close. I'll say, all right, so we're going to game plan what to do the next time you feel like that. And I'd like for you to see my colleague, Dr. Olson, like a psychologist, so that we can help you cope with those sorts of feelings. So I am pretty straightforward in terms of the questions that I ask.
Yeah, and I think before, like even in your presentation, we're talking about the tone and how you approach it, and it makes a world of difference to develop that a little bit of that trust and appreciation for the stress, and that can be overwhelming for the caregiving experience. And coming at it from that point of view, I think is very helpful. And from talking to other teams here in Ontario and Canada, is that most times that when you offer support to a caregiver or even the person who's abused, most often they are kind of accepting of it, is waiting for someone to sort of reach out to them and ask the question, right? So if we don't ask, we don't know. So there was a couple questions that just came in. Do you have any experience or suggestions in addressing abusive behavior by staff in long-term care that are very complex as the system rally behind their own? So I guess, I know that you're an ombudsman in long-term care. So I'm not sure if that, so obviously the systems are different, but in terms of your work, do you address those kind of issues of staffing?
Yeah, I do. So I'm a volunteer ombudsman, and which has been, I've been doing that for about 11, 12 years. So I do go into nursing homes, but I'll just say that I have a lot of opinions on this. So in the US, many of our nursing homes are for profit. And there are some CNAs or other caregivers in nursing homes who really are like, have no business being there, and they're really bad and problematic. But I would say most of the time it's up at the top level. They're not properly staffed. They're not getting paid enough. Like, so they get thrown under the bus for this sort of for this sort of behavior. And it's not acceptable, but also they're being asked to care for too many people. They're not given proper training. And I believe we have to start holding administrators and owners accountable, and physicians and pharmacists accountable, so that people aren't getting overly medicated as a way for them not to be a bother. And yes, I have very strong opinions about this.
Right.
We
Yeah.
could and should be doing much better than we're doing, and not blame the most underpaid, vulnerable people who work there, who for the most part are very well-meaning, but need more support.
Right. Yeah, no, that's a great comment. I know there's lots of work being done here in our country around the same issues that you just addressed as well. When somebody was asking about elder mediation, have you had any experience with elder mediation, or are they looking at that? I know there's been some webinars on with NCA about social justice approaches. So have you had any experience with that yourself?
Yes. In fact, I'm a part of a team, an elder abuse forensic center team. And we were just talking about that, where I said, how about mediation for this? Has anybody tried this? So a lot of like conflict, and a lot of finger pointing both directions, and who gets the money and who gets mom and all this sort of stuff. And so we're working with BetSEDEC, wonderful legal service agency in the Los Angeles area. And we're, I think in the next week or two, going to try a mediation approach. Otherwise, they're like, well, they need to be conserved and they need to be this. And can we just start by sitting down and talking with a skilled mediator? So I think we're just beginning to use that more, and understanding when it can and can't work. Sometimes people feel if the person has dementia that you can't do it, but that's not true. It just depends on the type of dementia and the stage.
Right. And there has been some movement here. There's some organizations that do. We have an Ontario Family Mediation Association, and they've moved into providing more support for older adults in abusive situations. So I think it's, like you say, it's kind of a slow moving process. Unfortunately, sometimes, in most cases, I think there's payment that has to be associated with that. So if people can't afford that, then that may not be an option for people. But trying to work through that and make it more accessible is another approach for that advocacy piece, right? Okay, so for just our last question before we wrap up, was just a question around some people with dementia might start showing signs of suicidal ideation, or partners feeling isolated if caregivers ask related questions. Do you have any ideas on that?
Sorry, this is for the person with dementia or the caregiver?
So some people with dementia might start showing signs of suicide ideation. Partners might feel insulted if caregivers ask questions. Are there any ideas? I'm not quite sure the framing of that
Sorry,
in
I
terms
don't
of
understand
suicide.
it well enough.
Yeah.
Good. Carla, could you clarify that just a little bit if you can?
Guess it's asking more. Yeah. So while we're just waiting, if
it might give you a little bit more insight. Carla had also posted this question in the chat box as well. And I'm just referring back to it to see if it gives us a few clues potentially. So Carla posted in the chat, the question of suicidal ideation might come up, but older people are often insulted when you try to help. Any ideas around intervening, assisting, or supporting?
Yeah, and so we always want to assess and two things. One, sometimes I've heard healthcare professionals think that somebody is suicidal when they say that they're ready to die, and they might not be suicidal. They might just be saying, hey, I'm 95, I've lived a good life, and and I'm ready to go, and I'm ready to go. I'm not looking to die, but and so sometimes we make wrong assumptions. For people who are suicidal, that we always assess kind of level of risk and readiness. And that's when I really call in my team members, psychologists, social workers, mental health experts to help us understand what's going on. With older adults, I also want to look at, are they on any medications? Because many medications have side effects that make people feel horrible. And that you can really give them a lot of hope that, let's give it a chance. I think you could be feeling a lot better than you're feeling if we just adjust these medications. You won't feel nauseated all the time or tired all the time. So I think also trying to understand why they've lost hope to that extent. I think that might be the best I can do, understanding that question best I can.
Great. Well, on behalf of my colleagues, Laura, she wants to come back online, and myself and everybody else at EAPO, I want to thank you tremendously for taking the time to share your wealth of knowledge with us today and answering all the great questions that came in and having such an interactive dialogue with our participants that are online. We hope to maybe bring you back again and maybe collaborate with the work that you're doing on dementia. We've had the privilege of also collaborating with Jennifer Story, who's, I think, also a colleague of yours, doing some risk assessment here as well in Canada. So thank you again, Dr. Mosqueda, and we will be in touch for sure. So just as a reminder, we do have lots of links that we'll share on our website after that Laura has shared with us as well, and her colleagues at NCEA, and we'll post those on our website as well. So on behalf of everyone, thank you again so much, Laura. Bye-bye. So now I want to turn it over to our next key speaker, and we have Denise Koster, who's going to join us. Denise, if you want to put your screen on. There she is. So thanks, Denise. And I know Denise was listening in on the presentation as well at the beginning. So she's heard the great information. I'm just going to stop the recording.